Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Angelini Pharma.
This program is presented by Medscape Education Global.
Hello, I'm Marco Mula. I'm an epileptologist based in London, UK. Welcome to this activity, Depression and Neurological Diseases, What's the Link? And it is my pleasure today to be joined by an expert in the field, David Okay. David, would you like to introduce yourself?
Hi Marco, I'm David Okay. I'm a consultant neuropsychiatrist who works in a neurorehabilitation setting as part of an integrated psychological medicine service. So we've got both psychiatry and psychology within that service.
Our aim today is to give you an appreciation of the mental health challenges linked to neurological diseases and equip you to better identify and manage patients with these common comorbidities. It can be challenging to diagnose depression in someone with a neurological disorder. Is that right, David?
Entirely right, Marco. I mean, depression can be missed quite frequently in neurological disorders. And I've got an example to share with you to illustrate the challenges to finding and treating depression appropriately. The cases of a 65-year-old retired teacher who had a left middle cerebral artery stroke 6 weeks prior to the problems that started as a consequence of the stroke. And she'd started to experience early awakening in the morning, a lack of enjoyment of her day-to-day activities, and slow thinking. Also had started to become increasingly guilty, and the service that she was under had conducted some screening tests, PHQ, which is a measure of depression, and they'd scored 18, which is in the moderate range. The family had become increasingly worried, and they had started to become quite strained, mainly because the individual was not initiating conversation as they might. So they wouldn't start conversations, and the individual will only reply monosyllabically. The individual denied sadness and wasn't engaging with the physio. So this lack of engagement really was impacting on their neurorehabilitation. In terms of medications, they're on clopidogrel, post-stroke, atorvastatin, prednisolone, and levetiracetam. And in terms of the concerns, the question was this depression? Was this another condition that looks a bit like depression, such as apathy, a well-recognised neuroscience condition, or was it both? Additionally, were other factors affecting the depressive symptoms? So medication, was that conceivably a problem? The challenges are, as is often the case, that of diagnostic overlap in conditions that live in the brain and the mind. So just in terms of the diagnosis of depression, DSM-5 defines depression as pervasive low mood. And so that's important. It's not just that you are sad or low sometimes, but it's pervasive, day to day, impacting on much of the activities that you're doing. It has to last for 2 weeks. It has associated lack of enjoyment. In technical terms, we call that anhedonia. And then we're also looking at a lack of ability to enjoy previous pastimes, also referred to as anergia. So low mood, anhedonia, and anergia as the common symptoms. In DSM-5, they're quite strict, and you need additional symptoms to supplement that. The real question is what impact this has on two areas of functioning. The first is your social functioning. So how is this impacting on your ability to engage with others? And how is it impacting on your occupation as well? So in terms of overlap in this instance, the difficulties are with neurological depression that fatigue is extremely common in the context of neurological conditions. You and I will both know that this relates to the range of pathways from the brainstem through to the frontal part of the brain, which can cause a fatigue-like condition, probably involving aspects such as the reticular activating system. Poor concentration additionally can be impaired by a whole range of neurological conditions, and those can be both cortical and subcortical in context. Sleep and appetite, much the same, again, oftentimes subcortical. And so those stem from neurological illness, but they also stem from a de novo or very valid depressive condition. In terms of apathy, an example might be an individual who performed an activity and gave no noticeable signs that they were enjoying the activity. But when asked afterwards, they would say, yes, I thoroughly enjoyed it. So there's no noticeable motivation, no signs that they did in the typical way. In depression, you typically get sadness, guilt, hopelessness, suicidality in the more extreme cases. But they kind of coexist. So you can have post-stroke depression and apathy. You can have Parkinson's apathy and depression as well. But it's important to identify them because the treatments may be different. So for example, apathy may respond to a dopaminergic treatment or a stimulant of some kind, such as a cholinesterase inhibitor, whereas antidepressants don't tend to work for that condition. And in the context of depression, the first-line treatments are very clear and evidence-based, which include antidepressants and psychotherapy.
And this is further complicated by the fact that there are different types of depression, is that right?
Yes. So when we think about depression in the context of complex conditions such as neurological conditions, we typically think of Jaspers hierarchy or Fould's hierarchy of conditions that might impact on presentation. At the top of that hierarchy is drugs and medications. Then there are organic structural conditions. And then there are a range of psychiatric conditions where one trumps the other. So for example, someone who was intoxicated with cocaine might have symptoms seemingly suggestive of a psychosis, but that wouldn't be classified as schizophrenia. Someone who has, for example, a depression in the context of Parkinson's would be recognized as an organic or secondary depressive disorder, secondary to the organic condition.
And how big is the problem of depression in neurology? What are the consequences of missing depression in these patients?
This is a really interesting question for me because it relates to service development. If you want to plan for treating your patients well, one has to recognize that there's a very high prevalence of depression. So if you're genuinely interested in addressing the needs of your patients, ideally you want both neuropsychiatry and neuropsychology embedded within neurology services. And when you're working towards articulating why that's necessary, it's because about a third of patients in neurology settings have a depressive disorder. And so, for example, in post-stroke, 30%, in Parkinson's, 40%, but a higher prevalence of anxiety disorders. In the context of multiple sclerosis, you have a 50% lifetime risk of developing a depressive disorder. And in epilepsy, the risk is 2 to 3 times higher than the general population. And so in terms of impact, it has an extremely marked impact on quality of life, much more so than the neurological disorder itself. So for example, if you have uncontrolled epilepsy, your quality of life will be impaired. But if you have a depressive disorder, it's markedly impaired. And the two can often co-occur. If you have a depressive disorder, there's strong evidence that your adherence to treatment is poorer, with a consequent worsening of your neurological condition in many an instance. And of course, your risk of suicide goes up. But importantly, not just your risk of suicide, your risk of dying several years earlier if you have depression, not as a result of just suicide, but with an associated physical health condition is worse.
A fascinating point replicated by many studies across different neurological disorders is that depression seems to precede the onset of the neurological condition itself. This obviously suggests a shared pathophysiology in many cases. What are your thoughts on this topic?
Yeah, so this is a fascinating topic and one that is only now starting to gain the recognition that it deserves. There was a large-scale study looking at MRIs for those with depressive disorders. What it showed was that the parts of the brain that are most neuroplastic are the hippocampi. They have the greatest ability to both shrink but also to regenerate. And in depressive disorder, your hippocampi tend to be smaller than population norms. So that's got huge implications, because what it shows us is that depressive disorder can change your brain structure in a way that is visible when you look across a large population group. And there are many ways to stimulate that hippocampal neurogenesis. The most common in the population is, of course, exercise. You go out, you exercise, you stimulate hippocampal neurogenesis. Antidepressants also stimulate neurogenesis. But this explains a question in psychiatry that has been present for many years, which is, why does it take 6 weeks for antidepressants to work? That coincides with the time frame necessary for hippocampal neurogenesis. And of course, the most effective treatment for the most severe depression, that treatment has historically been electric compulsive therapy. That has a direct electrical stimulation on the brain far more quickly, far more effectively than has historically been the case with the other treatments, and therefore you get a far more rapid neurogenesis effect.
And hippocampal neurogenesis represents a basic neurobiological mechanism in many neurological conditions per se, so probably represents a sort of shared neurobiology between depression and many neurological conditions.
Yes, exactly. So then, of course, you'll see that, for example, with the neurodegenerative disorders, such as Parkinson's disease, that they have a higher prevalence of depression, and it's likely part associated with that progressive involvement of brain regions, and therefore this influence of hippocampal neurogenesis. One other way of thinking about it, of course, is in the inflammation component of brain function, and depression is invariably associated with psychosocial stress, distress. High levels of stress can precipitate depression, and the main medium for that within the brain is cortisol. Cortisol, again, causes hippocampal shrinkage. In terms of risk factors, there were some famous studies done on depression which still remain landmark now, which were done in the 80s. And so it became increasingly clear, and there was subsequent very strong evidence, that social isolation remains the biggest risk factor for depression. So that's the social component of depression. There are other factors that can cause depression, which include more biological ones aside from the hippocampal neurogenesis that I spoke about. Steroids, for example, interferon, antiepileptics, which can cause both depression and anxiety. And then your cognitive coping styles. As you start to develop a range of neurodegenerative problems, for example, those subtle neurocognitive difficulties mean that your coping might be less, leading to a cumulative effect, a coalescence leading to a depression ultimately. And again, low social support, comorbid anxiety disorders, higher stroke severity, and associated disability all compound things, and again increase your chance of social isolation. And there are some interesting other considerations. Medications such as pramipexole, rasagiline can reduce depressive symptoms. Usually this isn't to treatment level. We're talking about 2 or 3 points on the Hamilton Anxiety Depression Scale, for instance, but it's an interesting phenomena that again highlights that complex interaction between the monoamines and depressive disorders. And again, just thinking about depression as an early biomarker, there is fascinating evidence that shows that in Parkinson's disease, several years before the onset of the motor deficits, people can develop depressive disorders. And that prevalence is higher than it would be for the general population. And what we're likely seeing is that the early disruption to parts of the brain, most likely the hippocampi, are resulting in a monoamine disruption. That is amenable, very amenable in most instances to treatment, but is an early sign of a reduction in neuronal function in those individuals. It's responsive to antidepressants because antidepressants restore monoamine function, but it's still an important biomarker. Unfortunately, it's not specific enough in its own right to be predictive. I'm sure there will be further work looking at what factors might aid that prediction component of depression. The important component of that is that when you have older adults who develop depressive disorders, we should be looking to see if there are other associated factors that might indicate early signs of a neurodegenerative problem. So for example, is there evidence of bradykinesia? Is there evidence of motoric slowing? Are they complaining of REM sleep behavior disorder, for instance, which might be an indicator of early neuronal disorder?
So David, how should we screen for depression in people with neurological disorders, and how should we treat it?
So screening, I think the most effective way is to ask an individual about how they're feeling and how they've been over time. And there's nothing that beats that. Understandably, in the current healthcare system, which is often under-resourced and overstretched, that's harder, especially in conditions where perhaps sometimes people that by their nature, if you're prone to social isolation, you may be prone to not wanting to speak about your mood. Screening measures therefore are helpful, and there are clinician-rated measures and there are patient-rated measures as well. That involves tools such as the PHQ-9, which is a quick, easy tool to use, the Hamilton Anxiety Depression Score, and the stroke adapted scales as well that you can find that have been validated with good clinometrics in stroke. And then of course, remember that in neurology in particular, the subcortex is a significant component size of the brain, so we should be looking for not just cortical dysfunction, but subcortical dysfunction to rule out the main two phenotypes of a subcortical problem, which are essentially disinhibition and apathy. And there we would therefore recommend that something like the apathy evaluation scale be used as well. Screen for sleep, screen for pain, those things are important comorbidities that impact on depression. And then of course review meds that might be causative. It's important always to check the severity of the depressive condition if people are genuinely feeling hopeless about the future, and assess their capacity to consent to treatment. So in terms of management, typically we talk about biological management, psychological management, and social management. The biological management we've already touched on. Examples include SSRIs, such as sertraline or citalopram. More effective second-line treatments are the SNRIs, and again, they often have a benefit in that they can treat comorbidities. So for example, venlafaxine is very good for neuropathic pain as well. And then we have agents such as mirtazapine, which are very effective for sleep in neurological conditions. Psychological treatments, which is an area of interest of mine. When I started my work in psychological treatments, there was an assumption that talking therapies would not be effective or as effective in neurological conditions. And in actual fact, we found that there's no reason for them to not be effective. So they are effective and have a benefit both for the patient, but in many instances also for the carer of the patient. And then to encourage getting out and about exercise and rehabilitation in the context of evidence-based treatments and therapies.
Thank you, David. So can you take us back to your patient and show us how you put all this into practice?
So it's important to recognize that with complex neurological conditions, the evidence base is for neurorehabilitation type treatments. And the importance there is to not think about doing this in isolation. So really you need a team. And so in this instance, we took a very careful history looking at symptoms of depression, and we found that this individual had both depression and apathy. There was a contribution by steroids and levetiracetam. There was a temporal relationship of their symptoms and the worsening in relation to the medications. And we also understood how this was impacting on them from a disability perspective, and they were accustomed to quite marked social interactions, and this was no longer as possible. The first step is to explain what's going on, because it's unknown to the patient, it's unknown to the family, so that process of psychoeducation is extremely important. They in particular will likely want to know what their prognosis is going to be. Is there scope for improvement? And we can instill hope there, and how we would expect that to work in the context of her stroke. We started a SSRI, and this individual was having problems with get up and go, so we started sertraline, which has a pro-dopaminergic component to it, and then talking therapies by virtue of the neuropsychologist as well. We reviewed the meds and rationalised those that were needed with a view to a clear time frame for reducing the symptoms. And then she had structured rehabilitation, including both occupational therapy, some advice on fatigue management, goals as well. And then safety plan over the next 4 weeks or so.
Thank you, David. And would you have approached this in a different way if the patient had a different condition, like epilepsy, for example?
Yes, that's a really good example. Yes, we would. Again, we'd have to look at the factors that tend to worsen the condition in the context of epilepsy. And for instance, that's often untreated seizures or seizures that are treatment resistant. We'd want to look at that. And if that was the case, bring it to a multidisciplinary team to review that. And sometimes that protected time for thinking about the patient's care is beneficial for many reasons. The first is it brings together the neurologist, the neuropsychiatrist, the neuropsychologist, the advanced nurse specialist. So you get a really clear picture, especially from the advanced nurse specialist, of some of the social aspects of care, because they often see the patient at home. And then if the treatment for epilepsy was still causing problems, you're also then able to talk very carefully about whether or not the current treatment plan is adequate, or whether we need to think about the more advanced treatments such as epilepsy surgery or another type of treatment from that perspective, VNS for instance. And then finally, just thinking again about whether or not it's necessary to change the medications because they're having an impact on the patient's mood is an important factor as well.
Thank you, David. So I think we have learned a number of important points that we can implement from tomorrow directly. We need to inform our patients that depression is a common comorbidity. We have clinical instruments that we can use in our everyday practice to screen routinely for depression. And depression in neurological disorder responds to treatment. We have antidepressants, we have psychological treatments. We have also need to keep in mind that mental health is a very relevant part of brain health in general. So if we want to keep the brain of our patient as healthy as possible, we need to consider mental health problems as well. So thank you, David, for this conversation, and thank you for your attention. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.